Okay, so this is video 3 of a 3-part series. We're going to talk about life support challenges and how they can be avoided. So I'm going to repeat the disclaimer quickly. This is not medical advice. I'm a healthcare provider, but I'm not your healthcare provider, so please talk about anything that this spurs you to consider with your own physician. And I practice in Michigan, so if any of these things seem specific to Michigan, I encourage you to explore that for what's applicable in your state. So our third scenario talks about Jonathan. He's 81 and he's on a ventilator in the ICU. His son Joe found him at home lying on the floor, called EMS and they did CPR and they regained a pulse and brought him to the hospital. Okay. So when Joe came in and saw his father's house, they'd been having regular lunch dates once a week and they would meet out in the community. And his dad was very, very private. And it was clear that he had really taken living on his own in this big house down to just a small area surrounding his recliner chair, the TV, and the main floor bathroom. So Joe was really surprised to see how much his dad's world had kind of shrunk since he'd last been in his home. Workup revealed in the hospital that he had urosepsis, which is a bladder infection that's also spread into the bloodstream, end-stage heart failure, and a hypoxic brain injury, which is during the CPR, even the best CPR, you don't get optimal blood flow to the brain. So his brain had been starved of oxygen and he was kind of in that state we talked about with the attempted resuscitation, is you can have a pulse come back, but you might not be interactive and be yourself. So Joe was on the ventilator and had vital signs, but was not at all interactive or responsive. Jonathan, forgive me. So we had a family meeting. The palliative care social worker and I met with Joe, and his wife Sue was a nurse, which can be helpful, but nurses were stubborn. It's Nurses Week, so I love us all, but we can be very stubborn and opinionated. So sometimes that's a plus, sometimes it's a challenge. Sue has been offering to help her father-in-law for years because she could kind of see where things were heading off in the distance, and he always declined her help. Joe offered to have him move into their home, and Jonathan, the patient at that time, upstream of this situation, had declined multiple times. Joe shared that his father's divorced, and he has 2 daughters that went to live with their mother after the divorce, and he had not seen them in over 50 years. So this is really common. It's a challenging situation healthcare-wise, but sometimes you have family issues that overlay, and it can be really, really hard for the family when there's not reconciliation. But Joe was still in touch with one of his sisters. Jonathan had not completed an advance directive or discussed his health care wish in his advance, so it all fell to Joe, but then there were these 2 sisters that we were obligated to try and reach out to, as we talked about in the first video, is that when there are children and no documented power of attorney selected amongst them, they all share equal decision-making power. And it's majority rules. So we asked Joe to imagine what his father would want in this situation. Sue says they did have a conversation where Jonathan said, I don't want to be on machines if I am not myself. It's not really specific, but at least was some conversation to help guide their decision making. Because he's not waking up on the ventilator, the plan is set to see if finishing the last 3 days of antibiotics will help improve his mental status. And Joe's calling his sister to reach out to the rest of the family and give them the opportunity to come see him. So when you're in the ICU, the hospitalist is in charge and the quarterback. Palliative team is one of the consulting specialties like endocrinology or neurology, but all of his body systems were having failure. So sometimes families will see your family in the room and you see one specialist at a time come in and say their piece because that's their focus. But our job as palliative is to kind of help put all the pieces together to give a realistic picture. It's not always a bleak one. Sometimes people think things are bleak and really they're not as bleak as they hoped. So in this situation, he really was having organ failure markers for all body systems. And so we went through exactly what that looked like. And we try to put it in very understandable language. This is very jargony, but that's where if there's not a nurse in the family, we try to put it in real concrete terms at like $10 words. I don't like $10 words. Let's just use regular words. So Joe asked questions about what these reports mean because he's very focused on the data and he knows his wife is a nurse and kind of help interpret them. And we help him sort through what all this jargon means. And he's saying that his father really rarely went to the doctor or shared any of his health conditions. This is all pretty much, other than what he could see on their weekly meetings, this is all pretty shocking to the son, Joe. So we met again and asked, they were having a very hard time deciding. Families are always in control of deciding or not deciding, but sometimes we kind of say, we always try to schedule that next time we're going to talk again before we end the first meeting, just to have another point, okay? At the second meeting on day 7, we'll talk about what these days mean on some future slides. Day 7 meeting, day 7 on the ventilator. Only Joe and Sue attend. The siblings and his 2 sisters did not come and participate. We did reach the sister Elizabeth by phone, and we have to say, because your father is in the hospital and all of your siblings are equal, we need to know if you want to participate in decision making, we can include you. And she said, no, thank you, I defer to my brother Joe. That's kind of our obligation to reach out and make that effort. And we were never able to reach the 3rd sister. And Joe was torn because he knows his father's suffering, but he's still hoping for some time for this sister to hopefully come and participate. The patient, Jonathan's not having any type of neurological activity after all the antibiotics are finished, and repeat tests verified that there was no longer an infection. So his ventilator was set to breathe at a certain amount a minute, and we can tell that there were no spontaneous breaths happening from Jonathan himself. The machine was doing all the work of breathing, which is also helpful information for the patient to consider, for the decision maker to consider. So we revisit the code status discussion because initially he was full code, and until everybody's input could be gathered, Joe didn't feel good deciding that without his sister's input, but since one was not participating or responding and the other one said she deferred to Joe, he felt confident with the information we provided that do not attempt resuscitation would meet his father's wishes. Joe does want all the IV medicines to keep his blood pressure in the 90s to continue, but then no new ones would be added. And because the temporary tube, there's a word missing there, it's supposed to be tube, because the temporary breathing tube will eventually fail. It's not meant to preserve your airway long term. There's a little balloon in there, and the tissue surrounding it becomes kind of eroded. And so there can be a loss of that seal, and there's an airway leak and a risk of bleeding. So that's why how many days on the ventilator becomes pertinent, because we want to try and help families make these decisions generally in the first week if possible, so that we don't start getting towards that 14-day mark when they have a higher risk of the tube failing, and then it's an emergency, okay? So the ICU decision is asking if they can have a decision tomorrow to either choose a tracheostomy, which is a surgical incision for a breathing tube down here, and a PEG tube, which is a feeding tube, and long-term acute care, which is like ICU care in another setting, versus hospice. This is another dilemma that we share, is that some physicians are really aggressive and want a date and want a deadline, and some are very much, you tell me what you want, and they follow the family lead. And sometimes there are pluses and minuses to both. Sometimes there can be legal implications to that. It can get very murky. Every physician wants to do the right thing by their patient, but we all have different styles. And sometimes a really aggressive family and a really laid back physician works. But if there's a mismatch, if both are laid back or both are really aggressive, you know, the dynamics can get interesting. So we're coming up on a decision point, and so far our calls to Elizabeth have gone unanswered. So this is a slide, it's very busy, but it's mostly so that you have something to take away, that you can kind of look at the steps in case you're ever in this situation again. I know they were like, well, you take it right down to the nitty-gritty. I did want to get really specific because these are things to think about if you ever find yourself in this position. For the people who do survive CPR and they're intubated, the first thing I coach families to think about is how alert is the person? If they're alert, how much brain function is left? It really depends on how much downtime they have, is what they call it. How many minutes was CPR performed for? Can the person write? Can the person blink their eyes? Are you having any type of sense of that person is aware and able to express themselves? Okay. If they're not alert, since they can only be intubated up to 14 days with a temporary tube, without any decision made, if that patient can't write for herself, like the patient in the first video who could write what she wanted, if we don't have any input or decision from the family or advance directive, then the next step automatically moves towards the tracheostomy and the feeding tube. So factors in the decision, I talked briefly about the first point, which is that it's a temporary tube, and that eventually the seal will be lost right around that, after that 14-day mark. We're really in the territory where we're worried about protecting the airway. And so your options, the fork in the road that you're at that point, is you're imagining, would that person want to be removed from machines and made comfortable and allowed things to happen on their own? Sometimes they pass away, sometimes they stay breathing on their own for quite a long time. Or is that person someone who's always valued a lot of interventions, puts a lot of faith in medical technology, and you get a sense that that's the approach that they would want to take, even if it meant not being interactive, even if it meant being long-term in a hospital setting on a ventilator. Okay, and we talk about that at length and as many times as we need to support the family in that decision. So long-term acute care is if you're in the ICU and you go down the road of getting a surgically inserted airway and a feeding tube, then you're moved into a long-term acute care facility. People who are in what they call a persistent vegetative state are either moved into an LTAC bed. Some hospitals have them where they can receive that intensive level care in the next care setting. Or some nursing homes in the area are certified to accept ventilator patients. There are currently 5 in the Metro Detroit area, so that not everybody can handle that complexity. And insurance coverage varies widely. Sometimes people can persist in that state for years. A lot of famous legal cases about what happens with people in this state. So talking through Jonathan's goals with Joe and his wife Sue supporting him as a decision maker, they shared that Jonathan was always a very, very private gentleman. Did not like his family coming into his home, always private. Didn't like medical care, going to the doctor. And he's currently not himself. And he had expressed to Sue that that was kind of the cutoff point where he did not want care beyond that. And then we also we talk to all the physicians on the case and say, what are your recommendations? And we share them with the family, and say, all physicians are recommending this. You have autonomy and you can decide what you choose, but this is what the physicians are weighing in to say. Everyone at this point for Jonathan was recommending comfort care because all options had been exhausted. So Joe says he was originally in denial about how severely ill his dad was. And he says, looking back, I can see he was declining, but I just didn't want to think about it. That's very natural. Joe had really hoped his sisters would come to see their father, and he's very sad that they had a full week to visit and didn't respond. It was really hard to watch him waiting for them. Sue was very supportive of any decision that her husband made, but from her experiences as a nurse, she feels that LTAC would not be in honor of what Joe wanted, and she said, I think he would call that torture. Nurses were just so blunt. So she was very clear on what she would think, but she would support Joe in his decision. She did feel that high intensity medical care was definitely not what he would have wanted because he wasn't even going to the doctor on a regular basis when he was healthier and in the community. So the plan of care for this family, Joe chose comfort care with hospice. Hospice is a separate team. I know it says our chaplains. We have hospital chaplains that work with all patients. Hospice also brings in their own spiritual support staff. And you can use any hospice that you choose. There might be one affiliated with the healthcare system, but you have a right as the consumer to choose any hospice of choice. Sometimes if you're in a hospital system, you feel like you have to go with the one that's attached to that system, and that's actually a myth. So it might take a little more hoops to jump through, but I help advocate people to get their hospice of choice in the hospital. They actually come to the ICU. He did want to wait until 5 for one last chance for a sister to come. She did not arrive, and at 6:20 p.m. they gave IV medicines for comfort. I always stress to families that the medicines that are given for comfort before a breathing tube is taken out are always doses that are high enough to provide comfort, but never ever so high that they would stop breathing. We don't use doses that high. That's another thing that people fear is that, well, I don't want you to just give medicines and turn everything off. And we coach people in advance that sometimes people breathe on their own afterwards. And so we come up with a short-term plan and a long-term plan based on how this person responds to that. But they're always kept comfortable, and it's, again, never to the extent that it hastens or shortens their time. Okay. The breathing tube was disconnected shortly after, and the patient died peacefully with Joe and Sue at the bedside not long after. So one nice benefit is that Joe and Sue are definitely sad, but they felt confident in this decision. They felt like they had exhausted all options, had all their questions answered, given all family members an opportunity to attend. And, sometimes the palliative team, we do write the orders for comfort and facilitate removing breathing tubes. We can do that, usually if someone's not expected to linger and there's a cohesive family dynamic. Because hospice to come for just an hour event isn't always the best use of their resources, and sometimes family wants that handled now, and we do that. But when it gets very complicated, hospice provides support for the family 13 months after the person dies to get you through all of those anniversaries. I think that's a wonderful feature that hospice offers that not everybody is aware of or takes advantage of. So in this situation, they not only provided a lot of support for them at the bedside, but they were able to stay in touch with them. They have grief support available out in the community because when family dynamics are tricky, it's what we call complicated grief. So a lot of families are in that situation. Yeah, I'm getting. So next steps, talk with your primary care provider about your illness. The Get Palliative Care website is, again, got the disease types to help you understand where you might be with your illness and complete your advanced directives. Thank you. Did I use up all my question time, or what do I do next?
I have a question here.
Okay.
Yeah, I have a question that it might be different now. When I was in my 20s, so a long time ago now, my father had a fall. He had a hematoma. He was in the hospital. I was going there every day. And they would say that the EEG, because this relates to saying no neurological activity. And they would say to me that the EEG didn't show anything. And in my 20s, back then, before internet and Google, and I thought, well, that just meant he was still unconscious. Sometime, and it's been a long time, but maybe the third, fourth day or something, I don't remember exactly, the doctors came in and they said, he's shown no activity on the EEG for so many days. Michigan is a brain death state, and we're going to be disconnecting the machines. Not do you want them disconnected, but we are going to be. Is that still the case? And what is the...
Yeah, that's an excellent question, and it is still the case. I just had this happen this month. There's a family where a relative was overseas and had not seen his mom for 20 years. And when someone's having no responsiveness at all, Michigan is a brain death state, and the medical team is obligated to do what they call brain death protocol. It's 2 physicians independently within a 12 hours apart, 24 hours apart. I have to look it up exactly, but within a certain time window, 2 independent examinations by physicians, and they do things to check for activity. They put ice water in your ear to see if your eyes react. Things that are kind of noxious, but they do an EEG. They look and see, is the person, they turn off the ventilator and see, is the person going to breathe on their own if the ventilator is turned off? And there's very specific measurements, because if there's any amount of reflex available, like brainstem breathing reflex available, once your CO2, what we exhale, gets to a certain high level, it prompts you to breathe again. So it's hard to walk families through this, but it looks at is there any type of response? Because the heart muscle is an automatic electrical system. The heart muscles are unique that they have their own electrical stimulus. So the rest of the body, including the brain, could be not functioning, but your heart will continue to stimulate itself. So that's how you can end up in a situation where someone has a pulse, but is failing all of these other tests for what we call brain death. And in that case, it was really heartbreaking. But the law requires that at that point, when the person is declared brain dead, they're technically considered no longer alive, and we're not allowed to provide, it's considered illegal to provide ventilator support and those things. So we help families through that. Some families do opt for gift of life. It's not always an option for someone with advanced illness. But yeah, it's a tough situation. I'm sorry that you went through that. Yeah.
Thank you.
Good. Thank you much.
Great place.